So it can, so very, very fine fibrosis can look like diffuse ground glass change, and only time and the evolution of that change will tell you what that was. So ground glass change doesn't mean airspace. Ground glass change doesn't mean interstitial change. It just means a visual description of what you're looking at. When you have ground glass change, the thing to notice is the lung next to it normal? So in this one, if you think that the ground glass is abnormal, you have to look at the lung next to it. Is the black too black, or is the black normal lung? In most cases, it will be normal lung. In some cases, the black will be too black and the white will be too white. That very starkly different attenuation between parenchyma next to each other can be very striking to look at. And that is what is typically described as mosaic attenuation. These days, we can describe anything as mosaic attenuation because mosaic attenuation, again, is not a diagnosis. It's not a very specific sign of anything. It is just a visual way of describing what you're seeing. So mosaic means like mosaic tiles on the walls or on a pavement. It just means different textures next to each other, like a pattern or a design. It doesn't need to be symmetrical. It doesn't need to be smooth. It doesn't need to be diffuse from the top to bottom. It can be isolated to one lung, but it's commonly described for both lungs. So mosaic attenuation can be described, for example, in this one, if you see the black and the white next to each other. In this one, if you ponder on the black one and say, is the black too black or is it okay? And if you can't really make up your mind, you can still describe this lung as mosaic. You're just implying that the parenchyma is diffusely abnormal bilaterally with changing patterns next to each other, not isolated to one lobe or one region. So both ground glass and mosaic attenuation are not specific of diagnosis. They are descriptive terms to just describe to somebody who's not looking at the scan, just reading your report of what you're looking at. This is, sorry for the amount of text on this slide, but this is just to talk about mosaic attenuation a bit more. Mosaic attenuation can be caused by two different processes. Either it's driven by vascular or it can be driven by airways. Airways meaning if the lung has hyperinflated or underinflated or filled with fibrosis, filled with ground glass or hemorrhage, or it can be that the vessel supplying that lung is abnormal. Either that vessel is stenotic or thrombosed, or over time with diffuse pulmonary hypertension. Any reason that makes the vasculature abnormal will be the vascular cause of mosaic attenuation. There's a lot of literature, if you want to read about very conservative ways of reading and assessing whether the black is too black, and then looking at the darker part of the lung and looking at the vessel size, and then comparing the small vessel size and the black or the hypo-attenuating lung compared to the hyper-attenuating lung, and then figuring out if the vessels are smaller. If you have a specific diagnosis in your mind, for example, if you look at that CT scan, if you've made up your mind that the cause is vascular, you can find a specific area in the lung that will make you happy, and you will be able to diagnose it that way or describe it that way. So I wouldn't put too much stress on the vascular appearance. This is more literary or more exam oriented. In real life, or even for diagnosing cases or reading cases for the exam point of view or the viva point of view, you wouldn't really be expected to have a very specific analysis that would be helpful. So the vascular causes can be the secondary causes or they can be the primary causes. That's the confusing bit. So if somebody has, for example, gross emphysema or COPD, if you have a part of lung that is chronically hyperinflated with COPD, and over time that is not contributing to any gas exchange, the lungs are very intelligent in the way that the vessels compensate. So if there's a part of a lung that is not contributing to gas exchange, that vessel will stop supplying that lung. So the vascular changes can also be secondary to underlying airways changes. That's why I'm saying don't stress too much about what the vessels look like on the CT scan. Just identify that there is mosaic attenuation. Instead of focusing on the small vessels in the lung parenchyma, you can look at the main pulmonary artery. You can look at the main history of the patient, the right heart thickening, the right heart dilatation. Signs like that are more helpful than focusing on the micro vascular structure of the lung on CT. Again, this is just to drive down the point. The mosaic attenuation, you can choose to a word you can choose or a term you can choose to describe an abnormality. In this one, for example, the sagittal view, the top is normal. This one has a bit of ground glass. On visual inspection, you can say that, oh, is this mosaic attenuation? Well, it is, but does it really imply a diagnosis? Is it helpful in any way? Not really. So would you be right in describing that lung, that axial section, as mosaic attenuation? Yes, you would be. The other sign we use very commonly, and perhaps the most important abnormality to identify in calling somebody definitively, giving somebody a diagnosis of ILD, is traction bronchial dilatation. So traction bronchial dilatation is a term that has replaced what we previously called as um, traction bronchiectasis. Okay, so bronchiectasis is a term that is reserved for primary bronchiectasis. Historically, what used to be called traction bronchiectasis is a term no longer acceptable to be used. So it's very important to keep in mind when you're presenting cases in exam setting, that if you say traction bronchiectasis, it implies that you're not really up to date, and you don't know that we're not supposed to use that term anymore, because bronchiectasis is a term we reserve only for primary airway abnormality. So airways, when they're dilated, they can be dilated because there's something wrong with them, or they can be dilated because there's something pulling them. If there is something wrong with the musculature or the wall of the bronchus itself, and over time it dilates, that's called primary bronchiectasis. If it dilates because there's something pulling it around it, either that's an acute abnormality or that's a permanent abnormality, that is no longer called as bronchiectasis. It used to be called traction bronchiectasis. If it was isolated to a certain part of the lung, it used to be called cicatricial bronchiectasis. Post-inflammatory bronchiectasis is still acceptable, but saying traction bronchiectasis is discouraged. So this first slice on the top is primary bronchiectasis, because you can see that the bronchi are dilated, but there is nothing around them to cause that. So is there anything to explain in the lung that the bronchi are dilated? No. So you have to, as an exclusion, say that this has to be primary bronchiectasis. Whereas in this bottom one, you can see that the lung around it is grossly abnormal. There's volume loss, there's architectural distortion, and the bronchi within it are being pulled. So as they're being pulled, they're getting dilated. And this is where you would use the word traction bronchial dilatation. This one, again, you can very clearly see that the lung around it is very abnormal. So grossly abnormal that this patient actually has signs of end-stage fibrotic lung disease. So one way of trying to figure out whether that's primary bronchiectasis or traction bronchiectasis, bronchial dilatation, is to look at the vessel wall, bronchus wall. Sometimes the bronchus wall can be very squiggly or irregular. That's usually a very specific sign of traction bronchial dilatation. So because a patient can have ILD and primary bronchiectasis, so if somebody has a mild ILD or mild reticulation that is very clearly more than would be expected for dependent change, and the question is, well, does the patient have underlying bronchiectasis as well? So that is when you would look at the morphology or the appearance of that specific bronchus. This one at the top, have a look at this and put some comments in the chat of what you think this is. Do you think this is primary bronchiectasis? Do you think this is ILD? Okay, take a minute and put something in the chat, and we'll come back and discuss it. Okay, a bit of divided response there. So my question was, is this bronchiectasis? Is this traction bronchial dilatation? As in, is this ILD or is this nothing? Um, some of you have said bronchiectasis. Some of you had said, I'm assuming you mean primary bronchiectasis. Neda has said air bronchogram in concept of consolidation, and that's absolutely right. This is consolidation. So this is the point I was trying to make. There is sometimes you can see dilated bronchi in consolidation as well, and that presence of air bronchogram can immediately make you think, is this bronchus dilated or is this ILD? This appearance is a bit more prominent that you would see in normal consolidation. So when consolidation heals, or when depending on which stage you're imaging the patient at, the air bronchograms within a consolidation can also look irregular. So if you had that scan and you saw those bronchi, you can't diagnose that as permanent. You can't diagnose that patient with ILD, even if you were uncomfortable with the degree of or the diameter of the airways. You have to recommend follow-up, because in most cases that will resolve when that patient improves and that consolidation resolves. You would see that the bronchi will go back to its normal. So within active infection, within active inflammation, you can see dilated bronchi, and you can't label that as a permanent change. You can't label that as ILD or primary bronchiectasis within active consolidation, was the point I was trying to make. Other abnormalities quite commonly seen in ILD are cystic changes. And this can be very hard to differentiate even for the most experienced radiologists. So don't be alarmed when you find yourself staring at a cyst and not trying to figure out whether this is a cyst or whether this is emphysema. It can be hard, and it can be even harder because of the fact that the patients that have cystic lung disease also happen to be the same patients that can have emphysema as well. So a patient can have both of them at the same time, and that makes it harder to diagnose. When it's a cyst that is thick-walled, like number 2, it's much easier to diagnose that. It's much easier to call that. But obviously, when you have thin-wall cyst and thin to the point that you can't even see the wall, or barely perceive the wall, then it gets slightly more tricky. If you look at number 4, you can see that this is a cyst because there's nothing else around it, immediately around it, that looks like that. You can see the wall. You can see it's a thin wall, but you can see the wall. When you look at number 1, and if the question is, does the patient have cystic lung disease, you have to look a bit more closely, and you have to look for the signs that can help you differentiate between emphysema and cystic lung disease. So in cystic lung disease, you are saying that the cysts are within the lung parenchyma. In emphysema, what you are saying that the cyst, what looks like a cyst or a space, is actually destruction of the airspace. So emphysematous spaces do not have walls. What they do have is remnants of structures that used to be normal lung stranding through them. So when you look, it's called a central dot sign. So the vessel that once upon a time used to supply that part of lung is still alive. You can still see a strand of it in the middle, and the surrounding airspace has since been completely destroyed. So in emphysema, if you look for the central dot sign, it will help you differentiate. So presence of a central strand, a central dot in a cystic space implies that this is actually what used to be normal lung once. So this is not actually a cyst, it's just end stage disease or end stage appearance of something. And in most cases, that will be emphysema. And in the context of ILD, that will be honeycombing, but we'll come to that in a bit. So moving on to more specific disorders, the first one we'll look at is sarcoidosis. Sarcoidosis is a very interesting disorder in the sense that not only is it multi-system, multi-organ, it has a very, very wide range of presentation in terms of what it can look like on imaging and also what the patient can look like. So sometimes it's an incidental finding. Sometimes the patients can be really, really unwell. And the age doesn't really help as well. They can be early 30s to late 70s. So it's a very difficult or interesting disorder to look at. And it also happens to be a big exam favorite for a lot of examiners. So it's really important to be clear on sarcoidosis because sometimes it can also mimic or raise the suspicion of underlying malignancy. So it becomes really important to be very clear on not only the stages, but also what imaging can look like and what you need to do. In terms of the stage of diseases, I'm sure most of you know these stages already, but just to put that into context, is the probability of complete resolution reduces a lot depending on which stage of sarcoidosis you are in. When you are in the fourth stage or in the stage of complete fibrosis or early established fibrosis in sarcoidosis, there will never be a point that your lung will return to normal. If your fibrosis is stable, you can live a normal life. If your fibrosis goes on to be progressive, you can end up with right heart failure or pulmonary hypertension. And in the end, the only resort you will have is to be put on a transplant list. Stage 1, stage 2, stage 3, still potentially reversible, completely reversible, but the chances of completely resolving reduce as you go up in stage. It is a multi-system disorder. I'm not going to claim to be a neuroradiologist and tell you all about neurosarcoidosis, but sometimes the patients can present with symptoms very far away from the chest or have nothing to do with the chest. And if the differential happens to mention sarcoidosis, they can end up having HRCTs to exclude sarcoidosis. The patients can be completely asymptomatic from the lung point of view, even if there is very clear abnormality on the CT. So sometimes the CTs are to look for sarcoidosis in an asymptomatic patient, or it can be an incidental diagnosis you make for non-specific symptoms. In terms of musculoskeletal changes, they can be appendicular silicon, they can be in the skull, they can be in the hands, the feet. Like I said, I'm not going to go into detail, but this is just to put into perspective that the patients can end up with an HRCT from a multitude referral sources. They can be orthopedic referral, a neurosurgeon referral, or a respiratory physician referral. If you had that skull X-ray in front of you, I don't think any of us would go with sarcoidosis being our first diagnosis. Most of us, and rightfully so, would think of diffuse or lytic metastases of the skull. So it can present in very alarming ways, in very progressive, destructive skeletal changes, but it can be multi-organ. And if the skeletal changes are very advanced, if the neuro changes are very advanced, it makes no impact, or it doesn't tell you in any way whether the lung is involved or not. So the severity of extrapulmonary sarcoidosis doesn't correlate necessarily with your thoracic implications or thoracic changes. And this is a Gallium scan. I will open up the chat again and ask if anybody knows what this appearance in sarcoidosis is called. Okay, 30 seconds starting now. Yeah, most of you are absolutely right. This is the panda sign that is seen on the Gallium scan. How many of us actually do Gallium scan in our every day-to-day practice in sarcoidosis? I don't think many of us do it. Again, this is a historical piece of information that is not really practiced very widely, at least in the UK anymore. We largely look at PET and MR and CT as the main imaging modalities we use for sarcoidosis. But panda sign is bilateral involvement of the parotid and the lacrimal glands in sarcoidosis. When it's superimposed on the normal uptake in the nasopharyngeal muscles, it can look like a panda's face. So that was what was described as the panda sign in sarcoidosis. This is called the 1, 2, 3 sign, or the typical chest X-ray that you will see. This will typically be in a young patient, early 30s, fit young man presenting with non-specific symptoms of lethargy, malaise, maybe low-grade fever. a very smart respiratory physician has done a serum ACE level, and that is increased, and that is what a chest X-ray looks like. So this shows you bilateral hilar enlargement, lobulated looking, and you can very clearly see that there's something in the right paratracheal space. So that's called 1, 2, 3. 1 being the paratracheal, and 2, 3 being the 2 hilar. Garland is a wreath or a string that is described to used to describe that appearance. This appearance is also called pawnbroker symbol or pawnbroker sign. These two signs are just used to describe the very typical appearance of bilateral hilar and right paratracheal lymphadenopathy in a very not so long ago. The same appearance you could see in TB as well, but this appearance of these signs are reserved more for sarcoidosis. The pawnbroker sign is just, it's an interesting sign. It's just the pawnbroker symbol is actually the symbol of the Medici family. So I don't know if many of you are very interested in history or not, but Medici family is the family of bankers that are famous for the art collections in Florence, Italy. But the Medici family symbol is actually 3 balls. That the legend was that there was a very famous giant that was slayed by a Medici man using 3 rocks that he threw at him. So that 3 gold balls hanging on a lamp are actually a symbol of the Medici family. So pawnbroker sign is a type of banking that the Medici family came up with in Florence. So that's why it's called that sign. So the pawnbroker is actually the Medici family, and the symbol is the 3 gold rounded opacities. Again, reiterating the stages of sarcoidosis, hilar and mediastinal lymph node enlargement is easier to diagnose, is usually the initial presentation in younger people. And the question, and rightfully so, the differential that needs excluding is lymphoma. Lymphoma is seen in the same age group. The lymph nodes, if uncalcified, can be more confusing with lymphoma. If you see specks of calcification, it becomes more easy. You don't really see calcification in the acute presentation. It takes time to develop. The enlargement comes first, and the healing stage and the chronic stage sees that lymph node calcification. If you have calcified lymph nodes and they're slightly enlarged, you're more reassured that it's a benign pathology. But when you have non-calcified lymph nodes that are large and rounded with the loss of the fatty hilum, you really have to sample them. Even if you're radiologically very sure that this is sarcoidosis, the procedure or the norm is that the respiratory physician will still sample these nodes endobronchially and will have tissue diagnosis of sarcoidosis. Sometimes we see parenchymal disease with the nodal disease, and that's obviously stage 2. Stage 3 is when you see parenchymal disease only. And like I said before, the chances of spontaneous resolution decrease as you go up in stage. And the 4th stage of when they present with pulmonary fibrosis is obviously completely, there will never be a point that they will resolve completely or go back to how the lung was before sarcoidosis. It's not uncommon to see people with stage 4 sarcoidosis having no memory or no history of ever having stage 1, 2, or 3 sarcoidosis. So they could have had sarcoidosis 10 years ago, 20 years ago, a year ago, and not have realized it symptomatically. And like I said, the degree of acute change or the changes in the stages 1, 2, and 3 do determine the chances of you getting fibrosis, but it's not a linear correlation. So it's not like if somebody presented with very severe disease, very large lymph nodes in stage 1, we can predict that they will end up with stage 4. It doesn't work that way. The parenchymal extent of disease is slightly more correlatable, but some people respond very beautifully, some resolve completely, and some just go on to have this smoldering disease that in a few years can become very aggressive suddenly. So there's no way of actually predicting the prognosis of it based on a scan. So these patients don't go under routine surveillance of scans. The scans or the follow-up scans are more dictated by the clinical scenario. So the respiratory physician will see the patient. If they look asymptomatic, if they're doing well, they're not going to be getting scanned again and again. If they do deteriorate, if the lung function deteriorates, they get repeat imaging. And whenever they get repeat imaging, the question to you or the chest radiologist will always be, is there active disease? And what they mean by active disease is their nodularity. You can have calcified lymph nodes, or you can have fibrosis and not have active disease. Fibrosis will always be fibrosis, even if it's stable and will stay exactly the same severity for the next 20 years. It's not classified as active disease. If you have lymph node enlargement that is calcified and is stable, it's not called as active disease. It's the parenchymal disease, the changes in the lung parenchyma that determine whether that is active disease or not. And the abnormality you're looking for is nodularity. Nodularity of the fissures, nodularity of the bronchovascular bundles. And when the nodularity is so advanced that there are a lot of small nodules sitting next to each other, they can also coalesce together. And what is traditionally called the galaxy sign. So it can look like there's a collection of nodules there, and it can also look like one large nodule. If somebody asks you, are you absolutely sure this is not an incidental cancer in the middle of all that sarcoid change? The answer is no, there's no way of knowing. Are you going to biopsy that? No, you're not. You're just going to go on and follow up the patient. These nodules, these coalesced nodules can sometimes be very prominent. They can be bilateral and they can be quite worrying looking. So then the differential for bilateral metastatic disease comes into play. And sometimes then when you don't see the micronodularity around it, and when you see these bilateral nodules, sizable nodules, it is sometimes worth getting a diagnosis just for reassurance purposes. This is just a magnified view of the nodularity. So nodularity of the bronchovascular bundles, perilymphatic, peribronchovascular, and the fissural nodularity. Whenever you have a scan that you are thinking down the lines of sarcoidosis, your eye should immediately be drawn to the fissures. If you scroll up and down and the fissures are nodular, you're pretty sure by that point that you are going down the right route and you are going to call that patient as parenchymal sarcoidosis. When it's stage 4, then the diagnosis isn't that easy to make, because you have a lot of other diseases that can give you upper to mid zone fibrosis, and sarcoidosis happens to be one of them. On a chest x-ray especially, the appearances are very non-specific. So they can be asymmetrical, they can be symmetrical more common. Upper to mid zone fibrotic changes. And then the differential has sarcoidosis in it. I will open up the chat and I will ask you guys to tell me what else that can be. So differential diagnosis for upper to mid zone fibrosis. 30 seconds. Okay, perfect. Thank you. And it's great to see all of you engaging with the chat, and all of you are giving very good differentials. Somebody has said advanced hypersensitivity pneumonitis, and I would really encourage you guys not to use terms like advanced. It's either acute or chronic or subacute. We'll come to HP in a bit, and hopefully by the end of today's session, you will know what to call acute and chronic in terms of HP at least. Yes, the difference is absolutely right. Upper to mid-zone fibrosis, particularly apical fibrosis, you can have TB, radiation, ankylosing spondylitis, silicosis, pneumoconiosis. And the thing that makes it slightly more confusing, especially with chest x-rays, is that not only TB, but RA, silicosis, pneumoconiosis, all of these can have calcification. So they can have lymph node enlargement of the same distribution, they can have lymph node calcification, they can have a bit of parenchymal calcification, and the differential doesn't really change. So if I now asked you what is the differential of calcified lymph nodes with calcified lung nodules and upper to mid zone fibrosis, your differential would almost be the same. So it doesn't really help. Once you have upper to mid zone fibrosis, you can't really narrow it down any further than the differential you already have, especially based on X-ray. And there is an appearance on CT that is quite specific to sarcoidosis. It's unfortunately not that commonly seen, but when it is seen, it becomes very easy. And those of you who have seen it once will always remember what it looks like. And the way to remember it is when you have a CT chest and it's a supine um, scan, what you want to look at is when it's sarcoidosis, it's upper to mid zones, and it looks like somebody has taken the bronchi and they have pulled them back. So, like if somebody was standing in front of you and facing the other way, and you took their arms and you pulled them back, that's how it looks like when you look at the lung. It looks like there's somebody pulling it back and laterally. So the bronchi are going to curve back and curve laterally. And all the architectural distortion, all the volume loss happens in that direction. And it's a very specific appearance. And once you see it, it's almost nothing else causes it. Especially if it's symmetrical. So if it's TB, it's going to be more irregular. When it's sarcoidosis, it's going to be more specific or more uniform. So that's what you can look for in terms of CT. So it becomes slightly more helpful. Can it be PMF? Yes. Sarcoidosis does not cause PMF. Uh, no. So PMF is progressive massive fibrosis. For those of you who don't know, this is commonly seen in occupational lung disease. So the posterior pulling is not specific to PMF. PMF can happen anywhere. So wherever that massive fibrosis or mass-like fibrosis is, it's going to pull towards it. So that PMF can also be in the lower lobe. It can be all over. It's predominantly upper to mid zone, but it's not specific to posterior architectural distortion. Again, CT upper to mid zone fibrosis. This is what end stage or fourth stage of sarcoidosis looks like. What happens in fibrosis is with the part of the lung that loses volume or collapses or becomes fibrosed, the lung around it is inevitably pulled to expand. So you have compensatory hyperinflation of the lung around it. For example, here you can see this part of the lung almost looks like it's turning into a bulla because the fibrosed part of the lung is pulling it. What happens in that scenario is that that will ultimately turn into a cavity. You can have a cavity inside a dead part of the lung or a fibrosed part of the lung, and that cavity is essentially a breeding ground for opportunistic infection. So that's what happened in this CT, and that space has actually grown in aspergilloma. So it's a very common complication in end-stage lung disease or fibrosis is when you have cavities, they do fill up with aspergilloma. This is a more typical appearance of the calcified lymph nodes and the volume loss. Again, a more advanced, more typical appearance, but if you can appreciate, it has gone down into the lower lobes as well. So the more severe the disease gets, the more it comes out of its comfort zone and starts going to the lower and mid zones as well. It is a multi-system disease, so at some point or the other, they may present with symptoms from another body organ, or abdominal pain, or cardiac arrhythmias, or general ill health. And if somebody does progress a lot, or they're quite symptomatic, they can have PET scans to look for uptake and extent of disease. In terms of cardiac abnormality, what was previously done with nuclear imaging is now done with cardiac MR. So I don't expect you to be experts in cardiac MR, but in terms of exam purposes, just something to remember by when you have infiltrative cardiomyopathy, or you have an abnormality in the heart muscle that has infiltrated the muscle with abnormal cells rather than ischemia, you have mid-wall or epicardial inflammation. So that part of the lung shows as late gadolinium enhancement on late GAD images and cardiac MR. So mid-wall enhancement is very typical for infiltrative cardiomyopathies, and sarcoidosis is one of them. We're going to come on to hypersensitivity pneumonitis. So let me see if we are coming up to, we're coming up to 7 o'clock. Let's take a 5-minute break, and when we come back, we'll start with hypersensitivity pneumonitis. See you guys in 5 minutes. No, yeah. Okay, so like I said, acute HP will ultimately turn into this legacy term that we won't use anymore. We'll use more non-fibrotic HP terminology. But for now, acute HP is a term we use to define um, abnormalities in the lung that are predominantly ground glass. This ground glass is typically nodular, but it can be diffuse. If very severe, if the patient had a very severe reaction to whatever caused them to have HP, you can even have consolidations. That patient is usually pretty unwell. If somebody presented with acute HP and had consolidations on their scan because of HP, the chances of them getting diagnosed with HP are very negligible, because the minute you have an unwell patient presenting to you and you have consolidation, you are going to call it infection. If nothing, you may put in a differential of organizing pneumonia or metastatic disease or something like that. HP is usually pretty low down on a differential for somebody reporting an acutely unwell patient with raised inflammatory markers and consolidation on a CT scan. So acute HP that has consolidation often goes undiagnosed. It's often in retrospect that we realize that that consolidation was actually all HP. It is more easy to differentiate HP from infective causes when you have the typical ground glass opacities that are nodular. The nodular opacities are very clearly central lobular in distribution. They are soft, as in they look a bit fluffy. Fluffy meaning you can't clearly outline their margins, but you can see that they are central lobular. They're usually small, small enough for you to see them, but small enough they're usually under 5 millimeter in size. They can occasionally have well-defined borders and even be slightly more dense. But if the history fits and the imaging fits, you can still be pretty confident that is HP. So this is what a scan will typically look like. They will have diffuse bilateral central lobular nodules. And how you know they are central lobular is because you will magnify it. You will go right up to the fissure and you will see that none of these nodules actually touch the fissure. When you go right up to the pleural surface, you will see that none of these ground glass nodules ever touch the pleural surface, ever touch the mediastinal surface. So you know this is sitting in a space that is incapable of touching the pleura. So that's only the central lobular space. And they are more commonly ground glass and fluffy, sub-centimeter, but they can on occasion be more dense. The only difference in acute and subacute when the abnormality is central lobular nodules is the time from onset or the time from the insult. And over time, this will be an arbitrary differentiation. So subacute, when the acute phase continues, when the very thing that is giving them hypersensitivity pneumonitis continues to be in that patient's life, they go on to develop more subacute HP. What happens is somebody has a very severe acute HP, they come into hospital, and this is seen pretty commonly. As they come into hospital, inevitably that thing that was giving them HP was left behind at home or at workplace. Because they happened to be in the hospital, they got well, and the doctors thought they got well because they were given antibiotics. So that starts the cycle of being undiagnosed. Then they go back home and they become unwell again. They come in again in the acute phase. Because they're in the hospital or they're away from that pet or that chemical, they get better. And they get labeled wrongly as resolved infection, recurrent infection. It's only when the acute phase was mild enough for the patient to be at home do they go on to develop the subacute phase, or more commonly when the patient is a healthy young person or a healthy adult, they cope with the symptoms and they have this smoldering HP that becomes subacute HP. Subacute HP is the most common presentation out of all three phases of HP. It is indistinguishable from the acute phase purely based on imaging. The diagnosis will be based on the onset of symptoms and the history. The acute and the subacute and the chronic, they lie on a continuum, and depending on the time, it is called a subacute. And even in the subacute phases, you can see early fibrotic changes or early distortion. And then if untreated, or by untreated, I mean they don't get rid of the substance or the PET or whatever is giving them HP, they go on to develop fibrotic changes. Sometimes, very rarely, they can even get rid of that antigen and still go on to develop fibrotic changes. This is technically not supposed to happen. And some people say that this happens is because you actually labeled them wrong. You didn't never actually found out what was giving them HP. So they could have HP because of multiple things. So technically, if they get rid of um, the chemical or the PET, they shouldn't go on to develop fibrosis. If they do, we do see it happen. And the theory is this happens is because there was still something else in their home or their workspace that was giving that irritation or that inflammation to the air spaces or the lungs. Subacute is usually bilateral, symmetrical, both lobes, all lobes, no clear zonal predominant. If it is slightly milder, you can see that it tries to favor the upper and the mid zones. Anything that we inhale and it irritates our air spaces tends to go in the upper to mid zones. If we inhale something that is heavy, and asbestosis being one of the very common things, then they settle into the bases of the lower lobes of the lungs, and those changes happen in the lower lobes. So if somebody says, why is asbestosis in the bases, whereas other inhalational or occupational lung diseases are in the upper and mid zones, is because of the substance they inhale, the weight and the size of it. So HP is usually caused by substances that are very small, airborne or inhalational, so fumes or pet hair or something like that, and they usually tend to favor the upper and mid zones. When they do develop fibrosis, the fibrosis is also very clearly mid zone predominant. It actually likes the mid zone more than the upper lobe and the apices. It can track into the bases, but being purely basal fibrosis makes it very unlikely to be HP. I'm just going to pause for a second, have a drink of water. So this one, when you can see that this patient does have ground glass or central lobular nodules, but you can also see that they started to get that architectural distortion. The bronchi have started to dilate. They turn this squiggly, irregular, beaded appearance. So that means that the lung around it is getting a bit fibrosed, a bit distorted, a bit abnormal. Technically, at this phase, this could still be reversible. If they heal completely, that could go back to a normal diameter of the bronchus, or this can be the first signs of the patient developing chronic HP. So this is worth mentioning on the scan that there is clear evidence that this is still a subacute disease. Because why is that? Because you see subacute HP, you want to see ground glass central lobular nodules. The presence of central lobular nodules implies active disease, and by active I mean acute and subacute. So because somebody can have chronic HP, and that doesn't mean that the patient needs treatment, especially if they're asymptomatic or the imaging has been stable for the last 5 years, so they don't really need treatment. They shouldn't, it might be an incidental finding on a scan. But when you see that central lobular nodularity, you know that this is active disease. And that's a question you will frequently get asked by the respiratory physician. When you report that scan, they might pick up the phone and call you and say, actually, I was wondering, does the patient have active disease? And what they mean, or what they're implying is there central lobular nodularity. Chronic HP being the last phase or the last bit in the continuum or the end stage of the HP being chronic means fibrosis. Fibrosis by definition implies irreversible, but you can have fibrotic features in subacute that may be reversible. Chronic HP favors the upper and mid zones. That favoring means that the reticulation or the architectural distortion favors mid zones. But the main sign that you want to see in HP is air trapping, and that air trapping is usually more clearly seen at the lung bases. So the lung bases can be abnormal in the sense that they show very clearly mosaic attenuation. And if you do an expiratory scan, it becomes more prominent. So you know it's air trapping. That can be more prominent at the bases, but the fibrosis itself has to be more prominent in the mid zones. Honeycombing, you can also see. Honeycombing is a sign I'll come to later. It's also seen, it can be seen in HP. So it doesn't mean that if everything else looks like HP, but you have honeycombing, you think to yourself, no, now I can't possibly call it as HP. That's not true. You can see honeycombing in end stage HP as well. This is what I meant by the air trapping. So air trapping is usually more prominent at the lung bases, and that's usually because of the breadth of inspiration or the amount of lung parenchyma you can see is more at the lung bases. For example, you see this different texture, different attenuation of the lungs next to each other. That same patient on the expiratory scan, you can see that this is worsened. So the dark part has gotten significantly darker. The lung around it has gotten significantly whiter. So that is clearly air trapping. Air trapping in a very small area of the lung, you can find in any expiratory scan if you look hard enough. What you mean by air trapping in the context of diagnosing somebody with HP is you want to see that air trapping bilaterally, at least one area in all the lobes of the lung, to confidently say that this is actually air trapping. The question you most commonly think to yourself, or somebody will ask you, is isn't it possible that the air trapping was airways disease, as in the patient has asthma and they still have a bit of ILD for some other cause, and they both happen on the same time in the same patient? And the answer is yes, that happens quite commonly. So that's where the distribution of fibrosis will come into play. That's where the history will come into play. That you have to put it all together and come up with a reasonable differential. But yes, you can have air trapping because of underlying mild airways disease, asthma, and the patient has ILD. So you can have both at the same time. This is what I mean by the distribution of fibrosis. So the traction is a sign of fibrosis, meaning there's something around it that is pulling that bronchus. So when I mean fibrosis, I mean traction. So the traction and the distortion in HP will be predominantly in the mid zones, predominantly upper and mid zones. So that's what you see in these slices. So mid zone, upper lobe, architectural distortion, traction. In the context of the bilaterally, the lungs look mosaic. It looks like there's air trapping. So that looks pretty good to call somebody as chronic HP. And the reason I'm calling it as chronic is because I don't see any nodules. I don't see ground glass, central lobular nodularity. So I know this is only chronic. You can have subacute on chronic. So the patient had chronic HP. They went on and got something else, a new pet, a new occupation that gave them HP or something else, or the same exposure to the same unknown antigen they had last time, and they can have the same thing over and over again. And that's quite common to see, subacute and chronic HP. Before we come on to idiopathic or the IPs, I'll pause for a second and see if you guys have any questions so far about HP. So 30 seconds. Can asthma patients develop HP? They can. Can HP patients develop asthma? They can. Will you be able to tell them apart on the scan? No. On imaging alone, any difference between acute versus subacute? If it's the patient is well enough to be ambulatory, as in the patient isn't on the ITU, isn't really unwell, and no, there is no way of differentiating acute versus subacute. The only way you can differentiate acute versus subacute is when the patient had consolidation as well. So they were so advanced or so severe a disease, they had nodularity as well as consolidation. So you don't really get consolidation in subacute. When you see consolidation, you tend to call it acute HP, but that is a very rare presentation. Is expiratory phase needed to diagnose air trapping? Absolutely. If you're going to label somebody as chronic HP, expiratory scan is absolutely necessary. So this sometimes that happens at the time of initial, it depends on your protocol. So if the patient was being worked up for ILD and they had a scan requested as specifically for HRCT, the initial broad assessment for underlying ILD will include an inspiratory spiral. It will include an interspaced expiratory. Some countries, for example, the American guidelines even recommend a spiral expiratory. We in the UK don't do that. And you can even have prone. So that's your initial assessment for ILD. Sometimes you can have a suspicion of HP come up from some other source. So the patient had a staging scan for some other reason, and the patient ended up with the ILD MDT saying, is this HP? So the patient never had an expiratory scan. So the first step would be to get a small limited study, a limited interspaced expiratory scan, and when you can definitively call that as air trapping on the background of lungs that look like HP, you are pretty sure that that patient has chronic HP. Effect of smoking on HP. Effect of smoking on anything isn't good, and HP isn't any different. The one rule of thumb was used to be true was the patient, if the patient has, we were told, I'm sure all of you were, that if the patient has asthma, they can't smoke, which isn't really true, because nowadays when you have vaping and all these, so by smoking you mean tobacco, and then there's vaping, then there's marijuana smoking, then there's all sorts of substances that are mixed in marijuana to smoke. So smoking in itself can give someone HP, especially if that smoking is not tobacco, if that smoking is vaping. So there's an entity that's quite interesting. If you guys Google it, it's called vape lung. So vaping related lung injury is quite significant. When it presents, it's very severe. We've had 3 or 4 in the last 1 year, and they look very bad. So vaping is it's kind of HP as well, isn't it? So yeah, smoking isn't good for anyone. Smoking alone, depending on what you smoke, can give you HP as well. Can ILD be unilateral? It can be. ILD can have all sorts of weird presentations, and it can be asymmetrical quite commonly. It can very rarely be unilateral as well. And then the question comes in, is that ILD primary ILD, or did that patient just have an infection on that side of the lung, or that patient had a hemorrhage on that side of the lung that they ended up with a scarred lung that looked like ILD? So that's a discussion of what's happening, but that technically, yes, they can. So moving on to idiopathic pneumonias, interstitial pneumonias. So the term that is used very interchangeably is UIP and IPF. And that is something I would really hope you guys get very clear in your mind by the end of today's session, is that IPF does not mean UIP, and UIP does not mean IPF. IPF is diagnosis. It is a disease. UIP is not a disease. It is a description of a pattern. So saying UIP doesn't mean anything. IPs are just terms to describe imaging. They are not diseases. So interstitial pneumonias and idiopathic pulmonary fibrosis are 2 different things. They're used interchangeably, and a lot of people who are not clear on the concept use the word interchangeably. So when you call somebody as idiopathic pulmonary fibrosis, you're giving them a death sentence. There is no cure for idiopathic pulmonary fibrosis. There are antifibrotic drugs. Those are very expensive, depending on which healthcare system you work in. They are hard to get your hands on, depending on where you are in the world. And the end stage treatment for any IPF is lung transplant. So pulmonary fibrosis is a very serious diagnosis. It is an irreversible disease that is a death sentence. So IPF is a disease that is a diagnosis of exclusion. Once you have excluded every other reason the patient can have bad lungs, you are left with a diagnosis of exclusion. So there is no test that will tell you that you have IPF. There is no symptom that will tell you you have IPF definitively. Lung biopsy can, but that is not a route we want to take commonly, because somebody with diseased lungs is also at a higher risk for complication from lung biopsy. So it's reserved for very specific questions. So just to repeat, IPF and UIP doesn't mean the same thing. The IPs, the UIP, the LIP, the DIP, NSIP, all the IPs are descriptive terms of what you see on imaging. Those patterns can be seen in many diseases, and that pattern, when you describe it, implies a certain differential diagnosis. It doesn't mean a specific disease. So that's the point that I hope should be really clear in your mind. The diagnostic process in somebody who has suspected ILD or diffuse pulmonary lung disease is you want to know whether that patient has IPF. That's the end point of any ILD discussion. When the patient has a scan and that scan is abnormal, the radiologist will describe the scan, come up with a pattern that they think fits that scan appearance, and that pattern will then open up a few differential diagnoses. For example, if I say this patient has this patient has da-da-da on the scan, and I think this is NSIP. So NSIP is not a disease. The respiratory physician and I will discuss the scan in ILD MDT. They will say are you fairly confident that you think NSIP is the best fit? And I will say yes. Then we look at a few abnormalities or the few diseases that can give an NSIP pattern of ILD. And those have specific tests that the physician will do based on what the patient is presented as. And that's how it will go, the diagnostic process. The scan alone will never give you a bond or clear diagnosis. Even if you have very clear traction, bronchial dilatation, honeycombing, all the tick points, and you say definite UIP pattern of lung diagnosis consistent with IPF. You shouldn't be saying that on a scan. You should be saying consistent with a UIP pattern of fibrotic lung disease. Why that patient had that pattern, you cannot possibly know. So don't give very serious diagnosis based on imaging appearance. So focus on the pattern and not the underlying cause. The pattern will guide you down a certain route, and that route is hardly ever explored by the general radiologist. It comes out of a multidisciplinary team meeting. So the pattern differentiation, the pattern classification is done by various societies. There are two large main classifications that are followed in the world. There's the American or the ATS guidelines, and there's the Fleshner Society guidelines. Depending on where you are in the world, you can follow either of them. There is a lot of overlap between them. The main difference between the American and the Fleshner is the push for biopsy in the American one. The American guide and the other difference being that the American guidelines actually endorse an expiratory scan that is spiral. That's a higher dose scan. Yeah, the Fleshner Society does not. Whereas the other difference being that the biopsy trend. So the American guidelines will suggest a biopsy on almost all the ILDs, whereas in the UK, or where we follow the Fleshner guideline, the biopsies are reserved for when you don't have clear answers on the scan. If you can make a fairly clear, fairly confident diagnosis of IPF based on the scan, we don't go down the biopsy route. So the UIP patterns, the definite UIP patterns and the probable UIP patterns don't really end up having biopsies because there are limitations, there are costs, there are waiting times and all that to consider. And this is unnecessary risk that should be avoided if it can be. Most places in the UK, we practice a hybrid sort of guidelines. So in some aspects we follow the ATS, and in some aspects we follow the Fleshner guidelines. This is not meant to confuse you, but this is just meant to put things into perspective. The only thing that would be important for you at your stage is to understand the main four categories that you want to put a scan into. So once you've made a diagnosis, there's definitely ILD. You want to then go down these four routes. Can I put it into any of these four boxes? And how you can put into any of these four boxes is we'll go through that in the next few minutes. The definite and probable UIP patterns are almost identical. There is only one difference between the two patterns, and that is honeycombing. We'll come to that in a bit. But these four categories are present in ATS and they're present in the Fleshner. So they're fairly similar in that sense. Definite UIP, probable UIP, both basal predominant, both subpleural. The main thing to consider for these two, definite and probable, is that you don't see any other predominant abnormality other than reticulation. So too many lines in the lung is the main problem. There is, or there can be, a bit of ground glass, but that ground glass change will always be considerably less than the degree of reticulation. So the main predominant abnormality is too many lines, reticulation, that happens to be peripheral, and it absolutely needs to be basal predominant. It can be anywhere in the lung, but it has to be worse at the base of the lungs. And by base, I mean lower half of the lungs, not back, posterior part of the lungs. If there is any feature on the CT, in addition to this, that is inconsistent with UIP, that means if there is too much air trapping, there are too many consolidations, there is pneumothorax, there's too many cystic changes, there is significant emphysema, any of that feature, in addition to those features that we want to see in UIP, would prevent that scan to be put in these two boxes. The distribution can be a bit abnormal, it can be heterogeneous, it can be asymmetrical. Very rarely, it can be unilateral, very rarely, and I mean once in 5 years, rarely. And the main difference between definite and probable UIP is presence or absence of honeycombing. You can have everything that looks like probable UIP, but there's still ground glass, but there's slightly more than you would want to see. So you want to call it probable UIP, but you're not really 100% sure. There's some ground glass that makes you a bit uneasy. There's some features that you can't really put here or there. Anything that eventually will end up being probable UIP, but today, right now on the scan, is indeterminate for UIP, gets called indeterminate for UIP. And why that is important is you don't want to label somebody as probable UIP, because when you put down somebody down that route, you close down other avenues. So keeping them in the indeterminate for UIP pattern box makes the referrer or the clinician think outside the box. So they will still look for other diagnoses that may be reversible, for example, like sarcoidosis or lymphoma or scleroderma, SLE, connective tissue diseases, drug-induced, anything that makes you slightly uneasy, you should err towards indeterminate for UIP rather than push it down probable UIP. When there is clearly abnormalities on it that make you think of alternative diagnosis, the alternative diagnosis we'll come to after this, for example, organizing pneumonia, for example, hypersensitivity pneumonitis, for example, dense calcified pleural plaques that make you think of asbestosis. For example, a patient that is known to have connective tissue disease, patient has RA, they have a dilated esophagus, they have joint erosions like you can see on the scan. So that's when you think of alternative diagnosis. So you will describe the features and you will describe the additional features and put in some additional possible differential diagnosis rather than calling it UIP or probable UIP. So how would you approach a scan that shows abnormalities? So first you will see whether there is interstitial abnormality or whether there is interstitial lung disease. Lung disease means a disease process that needs a workup. Abnormality can be a transient change, it can be an insignificant change, it can be incidental finding, post-inflammatory focal area of change. So ILA and ILD are not the same thing. ILA gives you a bit more luxury in describing an abnormality and dismissing it. ILD triggers the whole cascade of refer to respiratory, refer to ILD, MDT, and all that. So once you are sure there is reticulation, significant enough for me not to be able to dismiss it, you then want to look for fibrosis. And how you look for fibrosis is you look for traction bronchial dilatation. Once you have convinced yourself that you can see areas of the lung where the bronchi are being pulled, there is traction, you know there is ILD, and you also know there is established fibrosis. Once you have those, then you need to look at the distribution. Is it basal? Is it subpleural? Is it honeycombing? All three, check. UIP, check. Is there anything that is in addition to these findings that make me think of alternative diagnosis? Is the pleura okay? Are the lymph nodes okay? Is the patient known to be a connective tissue disease patient? None of that, UIP check. All of that present, but honeycombing absent, you need to call it probable UIP. And if there is anything slightly uneasy about it, there's ground glass that is a bit too much, and there is slightly architectural distortion more in the upper zones, you can't really call it basal. Any of these, feel free to call it indeterminate for UIP. So I'll put this slide up and then ask you guys, do you think there is ILD? And if so, in which three of these do you think there is ILD? So 30 seconds starting now. Okay. Okay, let's go through what you guys have said. So Shima has said A has effusions, absolutely right. So the patient in A has bilateral pleural effusions. Then they have this septal thickening at the lung bases. So what do you think that is? That would be fluid overload. So that wouldn't be ILD. B has consolidation, absolutely right. And some of you have said Faisal, Shima, Kanchan, AN, and Donna, that none of them actually have ILD. And you guys are absolutely right. All of this is just septal thickening for another cause. This is smooth septal thickening, but the subpleural lung looks very smooth and very normal. Septal thickening being more central. So this is septal thickening because of fluid overload, heart failure. This one is just consolidation and causing a bit of architectural distortion around it. So this is just linear atelectasis confusing you because the other lobe looks pretty okay. The subpleural part of the lung looks okay. And this in the context of pleural effusion should not be thought of as ILD. So none of these is actually ILD. Traction bronchial dilatation. So traction bronchial dilatation, by definition, you want to see something around that bronchus pulling it, whether that is reticulation or whether that is ground glass. It will be reticulation pulling that bronchus in UIP patterns of fibrosis. It will be ground glass attenuation around that bronchus and that bronchus getting dilated. So you will then think, is this ground glass fine fibrosis or is this ground glass NSIP? So NSIP historically was used to be classified as cellular NSIP and fibrotic NSIP, but nowadays we just focus on calling it NSIP rather than trying to focus too much on which type of NSIP it is. So I dilated bronchus. The lung around it is completely normal. It's primary bronchiectasis. A dilated bronchus, the lung around it is abnormal. It's traction bronchial dilatation. If that abnormality is traction, that is a UIP pattern. When that area around it is ground glass, you start thinking of NSIP. When that consolidation, when there is clear consolidation around it, you have to think whether that is reversible, that is just normal infection finding. And I'm sure all of you will appreciate that in C, you have this consolidation and you can see bronchi through it. So this is just air bronchogram. This is not traction bronchial dilatation. You see bronchi more clearly when they're in the middle of a white area like consolidation. So they're more striking or more appreciable, but that doesn't mean that they're dilated. In B, the bronchi are the typical squiggly, irregular, worm-like, and the lung around it is very coarsely reticular. So there's coarse reticulation, subpleural predominantly with dilated bronchi reaching up to the pleural surface. So that's traction bronchial dilatation. The first one is very subtle. That's why I put it in. But if you focus closely, there is traction bronchial dilation. There's a thin bronchus going all the way up. It is irregular, it is non-tapering, and the lung around it is coarsely reticular. So all three, the first two is traction bronchial dilatation, and the third is just common consolidation with a bit of air bronchograms. The other thing to think about ILD is not to overcall it. If the patient is a 92-year-old with no other symptoms, presented with the KCT-KUB, and you can see the base of the lungs, the base of the lungs don't look perfect, don't go ahead and call it ILD. There is something called age-related change or age-related ILD. With age, our lungs get stiffer, less elastic, so they can look a bit abnormal on imaging. It is forgivable up to a certain stage. And beyond a certain age, you have to think pragmatically whether is there any benefit in overcalling or pushing this patient down a diagnostic route for very mild early changes, or can I dismiss this as age-related changes? For example, in this one, if you look, if this was your first scan and you saw this subpleural change, and this patient happened to be a 95-year-old, I would urge you to err on the side of undercalling it and just describing it and saying maybe attributed to patient age. If this was a 60-year-old and you had these lungs, you shouldn't be calling it as age-related change, because that would then, in the context of age and especially symptoms, make you think of, is this early ILD? And the only test in reality is follow-up. So when you see these patients followed up, if they actually had no symptom at that point, it would be not unreasonable to recommend a 1-year follow-up. So if they came back in 1 year and they ended up with a scan like that, you know they clearly have ILD and it is progressing. If this was the initial scan, you would be way more confident calling this ILD. But on the first one, depending on the age, the patient presentation, that your report would be tailored according to that. But if you do look closely, you do see a bit of traction there as well. This is a very medial part of the lung, especially near the lung bases, is where we have degenerative changes in the spine. So you can have dense, prominent osteophytes sitting there. So you can have focal fibrosis next to degenerative changes of the spine, and that's not ILD. That is just the lung reacting to a foreign body. So the osteophyte is pressing into the lung, and the lung around it kind of reacts to it. So that's not ILD. You can describe it if it's very prominent, but you can say that's focal fibrosis related to degenerative changes of the spine, does not need any further workup, because that will almost certainly be asymptomatic. The other thing ILD can mimic as is dependent change. So if you look, especially in the acute inpatient setting, unwell patient, a heavy patient, patient who's been lying in bed for a long time because they're unwell for some other cause, if you CT them, it's very common to see dependent change. So dependent change by definition should be dependent, and with time and the number of scans you report and the number of years of experience you have, you get pretty confident calling it as dependent change, and most of the time we don't even notice it anymore. When that dependent change shows up on a scan that was done to look for ILD, then you look a bit more closely, then you start noticing everything more closely, then you start confusing yourself. So if that was your scan for ILD investigation, and you saw this change, if you can see and convince yourself that this change is only in the dependent parts of the lung, whether that is fine reticulation or whether that is subtle ground glass, it will be dependent change. When that change starts creeping up laterally around the lung in more interior areas is when you should start getting uncomfortable by dismissing it. And especially when you can see the bronchi getting dilated in it or around it, you then start to think whether this is a bit more than I would dismiss it. The first step would be to recommend a prone scan, because on a prone scan, they should improve or resolve, and that would tell you whether this is a dependent change or ILD. But it's certainly worth asking yourself that question when you see the changes. If you see changes, look for them anteriorly and laterally. If you can't find anything to yourself, is this all just dependent change? Am I overcalling ILD? So what is honeycombing? Honeycombing is a sign that is associated with end-stage lung fibrosis. It's just end fibrosis, the end of the air spaces, architectural distortion progresses and progresses, and then the normal tissue through distortion ends up with end-stage cyst formation. This cyst doesn't need to be stacking. They don't need to be on top of each other. Even one cyst can be honeycombing, but your confidence in being able to diagnose it as honeycombing should be very low when it's just one cyst you see. So that's why we ideally recommend that when you see a cyst sitting right up to the pleural surface, can you convince yourself this is just a cyst, or are you sure this isn't a bronchus that is seen out of pain? So the lower half of the bronchus is in another slice, and you can see the top end of the bronchus sitting on the pleural surface, and it looks like a cyst, but just an end-on bronchus. When you see them stacking up to each other, 2, 3, then you can be sure this can't be a bronchus. And that's why traditionally we want to see 2 or 3 cysts stacking up before we call it honeycombing. The honeycombing doesn't need to be on the lateral part of the lung. It can be paramediastinal, it can be next to the fissural pleura. It can also be right in the middle of the lung, because it will look like in the middle of the lung, but it's actually the base of the lung. So on the basal slices, you can see honeycombing right in the middle. But if you look at sagittal, this is actually the lower surface of the subpleural surface. Honeycombing means end-stage fibrotic lung disease. It does not mean IPF, it means definite UIP. You can have definite UIP pattern with IPF and many other diseases as well. It's not really helpful, but it's certainly worth pointing out that you can see honeycombing in non-UIP pattern as well. For example, NSIP and HP can also show honeycombing, but that should be certainly not be the predominant factor. So I'll pause here and make sure you guys understand so far. If you have any questions, put them in the chat. Give you 20, 30 seconds. What is bronchiectasis? Bronchiectasis is that end airway dilating all the way up to the pleural surface. And how can we, bronchiectasis versus bronchiectasis. Bronchiectasis is a primary abnormality of the bronchus. Bronchiectasis is only seen when it's fibrotic lung disease, because the end airway doesn't really have that much muscle in it that will have primary bronchiectasis. So when the end airway dilates all the way, it's almost always because of fibrosis. One small cyst with reticulation can be called UIP. Absolutely not. No, you want to be really confident and you want to err on the side of caution before you label somebody as definite UIP. If you have one cyst with reticulation, that's not indeterminate for UIP, that's probable UIP. Is it mandatory for honeycombing to be layers? It is not. It depends on your experience. If you are a very experienced cardiothoracic radiologist, even one layer of honeycombing you can call as honeycombing. But my question to you would be, are you sure this is not paraseptal emphysema and this is honeycombing? You don't really know, do you? So it's better to see it stacking up, but there is not a technical requirement for it to stack up. One, if you ask me in the question higher up, can we use emphysematous cyst or just cyst? You cannot use emphysematous cyst because emphysema means destruction of the lung. Cysts mean a space occupying lesion that is a cyst. A cyst can be a tumor, a cyst can be a bronchocele, a cyst can be a pneumatocyte, a cyst can be congenital. So yeah, don't call it emphysematous cyst, call emphysema and cysts. And I hope you would attempt to differentiate between the two. Like I said before, cysts have wall, emphysemas do not. If there is a thin wall parenchyma cyst, how to differentiate between emphysema versus pneumatocyte? Pneumatocyte is usually caused with an insult to the lung. So either infection and most commonly trauma. Pneumatocytes are seen as a result of acute injury to the lung. It is like a pop of the lung. It happens with blunt trauma. It can happen with infection, especially PCP, pneumonia. That's pneumatocyte. Pneumatocytes can have a wall or they can look like they have a wall. Emphysema should not have a wall. Emphysema is not a lesion. Emphysema is just empty space where lung used to exist. So how to differentiate emphysema is you want to look for that central dot sign. You want to see a strand of tissue going through that cystic area. You want to see a dot hanging in the middle of that. That is a vessel that used to feed that part of the lung. You want to see a strand of septa that will likely be containing that vessel in it. So that's how you differentiate emphysema from cyst. Emphysemas do not have walls and they usually have something hanging in the middle. This is how typically you would be very happy calling it as honeycombing. You can see stacks and stacks of cysts and you can see a dilated bronchus going into it. If you saw that, you would be very comfortable calling that as honeycombing. The problem happens when they're not so obvious. So for somebody who have asked before, what is bronchiectasis? This is bronchiectasis. So this is that bronchus. This bronchus you can see going and then disappearing. This is a cyst sitting next up to the pleural surface. And this cyst is likely another bronchus that is seen on another slice, either above or beyond it. So that's bronchiectasis. And because this is one cyst, you shouldn't be happy calling this honeycombing. When you see these, this is cyst on cyst. So 1, 2, 3, 4 cysts. This on A is definite honeycomb, definite UIP, and B is probable UIP. Other than the honeycombing bit, there isn't any difference between them in terms of distribution or other morphological features. NSIP is the second most popular IP. NSIP by default is assumed to be caused or associated with another disorder. So NSIP is usually seen in connective tissue diseases or associated with some other diseases. So the patient can have underlying connective tissue disease, they can have an autoimmune disease, they can have drug-induced toxicity, something else going on with them. So if you have a scan and you labeled it as NSIP, that referrer will inevitably order 100 other tests to look for what is going on. They will do all sorts of antibodies, ANCA, SLE, scleroderma, RA, all sorts of things. They will look at the drug history, they will look at the patient history to look for other underlying disorders that are associated with NSIP, most commonly connective tissue disease. So it's a rarer diagnosis, much rarer than probable or definite UIP. And when you do diagnose somebody with NSIP, they have to have other disorders excluded. And once they are excluded and you're left with purely NSIP, it is rare, but it can happen. And what happens with NSIP is it can evolve. And like I said before, these interstitial pneumonias and pneumonitis is just a pattern of ILD. Somebody has NSIP today doesn't mean next year they're not going to have UIP. So the pattern can evolve. The only pattern that does not evolve is definite UIP. That's why the word definite in it, and that is why the reluctance to not overcall it. If you have called somebody as definite UIP, the understanding is this pattern will never change. The severity can progress, but they will always be definite UIP. NSIP by definition, probable UIP by definition can evolve. NSIP can turn into probable UIP. Probable UIP one day can have superimposed viral pneumonia or infection or acute exacerbation, and they can look like NSIP. Or they can both progress into definite UIP. But once in definite UIP, they're not going to progress in any other way other than progression of severity. This scan, give it a go. I would like you guys to define what the abnormality is and give it a pattern, and we'll go from there. 30 seconds, starting now. Okay, let's look at the scan again and look at the predominant abnormality. The predominant abnormality on the scan is ground glass, not reticulation. So you can see ground glass on both sides. It is clearly more on the right side. The ground glass has a bit of texture to it. So I think some of you may be confused by the texture and calling that reticulation. But if you look at the periphery, those lines are actually just dilated bronchi, and the predominant abnormality more centrally and anteriorly is ground glass. That ground glass is clearly causing traction because the bronchi are very significantly dilated within that ground glass compared to outside it. So bilateral abnormality, the predominant abnormality being ground glass. The ground glass is clearly causing traction, bronchial dilatation. Why you know this is traction and not primary bronchiectasis is because outside that ground glass, there is no dilatation. So can this be an acute finding that is reversible? Yes. But if I told you this looked like this, a little similar to this, but this has progressed over the last 6 months, then you would certainly think, is this ILD? Is this predominantly ground glass with traction? So the best fit would be NSIP. Can this progress into probable UIP or change into probable UIP and ultimately end up with the probable definite UIP pattern? Of course it can. But right now, on this scan, this is an NSIP pattern of disease. The other pattern you guys need to think about when you see bilateral abnormalities in multiple lobes is organizing pneumonia. So organizing pneumonia can be an entity in itself when it is called cryptogenic organizing pneumonia, or it can be organizing pneumonia due to another cause. Organizing pneumonia is also a pattern of distribution of abnormality on the CT. It is not a disease. The disease is cryptogenic organizing pneumonia, and that means it is organizing pneumonia without any cause, and that is a diagnosis of exclusion. Most recently, the disease we all reported plenty of, unfortunately, was COVID. And organizing pneumonia was one of the patterns very clearly seen and associated with even COVID. So a lot of infections, a lot of drug reactions, a lot of drugs, pharmaceutical drugs, recreational drugs can look like organizing pneumonia. That organizing pneumonia is not cryptogenic organizing pneumonia. It is organizing pneumonia appearance of an infection or an inflammation. When you have no other cause for that organizing pneumonia, you end up excluding them. You end up with cryptogenic organizing pneumonia. This used to be called BOOP. Now it's called COP, or organizing pneumonia. The feature you want to see especially in an exam scenario, you want to see fluctuating consolidation. So today they presented like this. They would improve, and they won't improve in antibiotics. They would improve with steroids. 6 months from now, they presented the same way, but this time the areas we saw previously had gotten better. They had new areas in new locations. So fluctuating consolidation or fluctuating ground glass. Bilateral can be any lobe, any distribution, distribution as in within the lungs, top to bottom, can be organizing pneumonia. The pattern of organizing pneumonia is bronchocentric or subpleural. And when you see it bilaterally and extensive, it becomes more easy to diagnose it. When you see it subtle, for example, here, you might not think of organizing pneumonia. The thing about organizing pneumonia, cryptogenic organizing pneumonia, is an ILD. So when you have diagnosed or excluded other causes, and you're left with a scan that looks like this at the top, you have no choice but to call it cryptogenic organizing pneumonia. If these patients respond very well to steroids, but they can't be on steroids forever. So they get medium to long-term steroids, then they are tapered off, they can recur or relapse. So it's a constant struggle to find that balance. Some do really well, never have another flare again. That's not to say they're not going to have another flare in 10 years' time. Completely cryptogenic, nobody knows why it happens, but that's what it looks like. It looks like subpleural consolidation. It looks like bronchocentric consolidation. It can be consolidation, or it can be ground glass, or it can be both. This can resolve completely, or it can resolve with a bit of scarring. And by scarring, I mean a bit of architectural distortion in the areas that consolidation used to be, or they can end up with a progressive fibrotic ILD. So that scarring would keep progressing, keep pulling the lung around it, keep distorting the lung around it, and they will end up with chronic OP, or chronic organizing pneumonia, and that's a fibrotic lung disease, which unfortunately has no cure. That's the evolution of it. That's the acute presentation of it. You can have pleural effusions, but that's usually a reactive pleural effusion. It can confuse you a bit because you start thinking down the infection line when you see pleural effusion. But you see bilateral subpleural bronchocentric consolidation with air bronchograms that over time, weeks to months, will start evolving into distortion. So you start seeing that irregular pulling of the bronchi. You see the irregular squiggly margins. That can be reversible. But weeks to months, when that consolidation completely goes away and you're left with that distortion alone, that would be scarring. If that keeps evolving or the patient is symptomatic and it keeps progressing, that is fibrotic OP. Rarely you can see a purely bronchogenic pattern of OP. This is very rare and is usually seen in drug-induced or chemotherapy-induced diseases, or opportunistic infections can sometimes mimic this, but it's purely bronchocentric. So along the bronchi, the inflammation sits. It looks very pretty on a scan. It's a very striking appearance. It's also very rare to see this appearance because when you, in real life, more commonly, when you have this, you have subpleural consolidation as well. This is a very specific pattern of OP, rarer, but obviously becomes more easier to diagnose because you can't really call this infection or anything else, can you? So DAD or DAD, depending on where you are in the world, is diffuse alveolar damage. It just means that the lungs or type 2 pneumocytes and the endothelial cells undergo necrosis. It's usually driven by a cause. So the cause can be ARDS, the cause can be an ischemic insult, pancreatitis even, or it could be idiopathic without a cause. So when it's idiopathic, diffuse, severe pneumonitis, that's called AIP, or acute interstitial pneumonia. Diffuse alveolar damage is a term used to describe severe bilateral abnormalities. You can't really tell whether this is interstitium or the lung space, the airways, or it's also severe. You can't really differentiate anything at all. It can be described as diffuse alveolar damage. It is a term I would discourage you using. And it's usually reserved for ITU sort of patients when the changes are so advanced that it's like a spectrum of when you don't know whether this is ARDS or this is diffuse alveolar damage, whether there's a bit of hemorrhage in the middle, whether they had vasculitis or that caused a cascade of events. It's a descriptive term. It has an acute exudative phase. If the patient survives it, it's hard to survive it, but in modern medicine, the ventilator supports young patients, healthy, fit patients can recover from it. And if they do recover from it, sometimes the recovery can be very remarkable. Then the reparative phase starts. The repairing phase of it is actually more damaging to the lung because it's causing distortion and fibrosis and pulling and almost permanent damage during that repair. So that repair the kind of repair the lung goes through will determine what they will end up as an end stage deficit in terms of lung function. So it's the most common presentation of diffuse alveolar damage is drug-induced. And by drug-induced, I don't mean recreational drugs. I mean chemotherapy drugs. Immunotherapy drugs can cause that. When you stop the drug, the patient improves. What happens is sometimes these chemotherapy drugs are used in connective tissue diseases, and patients with connective tissue diseases can have abnormal lungs, and the drugs they give them for those connective tissue diseases can give you those lungs. So it gets really hard to differentiate it. And usually it's a mechanism of looking at when they started a drug and trying to hold the drug for a few weeks or months and see how the patient did. But it can be confusing. Again, diffuse alveolar damage can look like diffuse ground glass, patchy, tending towards consolidation. It can be basal or it can be everywhere. Just to point out that when you see diffuse ground glass and you see traction in the middle of it that looks so uniform, you can't really call that diffuse alveolar damage. So the word you should be thinking of if you saw that scan is NSIP, because you don't really see distortion. You see almost radiating dilated bronchi sitting in diffuse ground glass lung. So this is actually fibrotic NSIP. This pattern I put in there because this is a pattern of diffuse alveolar hemorrhage and not diffuse alveolar damage. Both happen usually at the same time, but when it's purely hemorrhage, the patient obviously is coughing up buckets of blood, and that pattern is very typical of diffuse alveolar hemorrhage rather than damage. Coming to CT ILD, I'll pause here because I know this is getting confusing. So I'll pause here and make sure you guys don't have any questions before I move on. 30 seconds for questions, please. So when I say bronchocentric, I mean it's tracking along the bronchus and then the end airspace, so the bunch of grapes around it. So it's when you see a nodular focus of consolidation, you can see an airway coming into it, and that's bronchocentric. Or you can say peribronchial when it's going along linear to the bronchus, so interchangeable. Peribronchial when you want to say linear, when you say blobs of nodular consolidation, when you can see a bronchus going into it is bronchocentric. Can OP be diagnosed on the first scan, or do we need follow-up scans? You can diagnose it on the first scan. When it's OP and it's clearly OP, it's very nice to look at. And when you've seen it, you can, if you're confident, go ahead and call it. Like I said, you're describing the lung appearance. You're not really calling it COP. I think your question is, can COP be diagnosed on the first scan? So the COP cannot be diagnosed on the first scan. Organizing pneumonia can be. Whether that organizing pneumonia is cryptogenic organizing pneumonia or that organizing pneumonia is COVID or nitrofurantoin lung or chemotherapy-induced lung. You can't. How to differentiate fibrotic NSIP and DAD? So the DAD patient or the diffuse alveolar damage patient is very, very unwell. That patient is in the ITU. That patient is not sitting up and talking to you. NSIP patients are ambulatory patients walking around, being worked up of ILD, because something that develops slowly over months to years, the patients cope really well, and the patient over months has reduced exercise tolerance, and they're not really that unwell looking. Moving on to connective tissue ILD. So connective tissue or CTD ILD is a term reserved for interstitial abnormalities in patients that have known connective tissue diseases. The most connective tissue diseases you get asked about in the exam are these 5. So SLE, RA, scleroderma, Sjogren's, and there is a lot of overlap. The one that is slightly different from the other 4 is RA. RA is the only one that presents more commonly with UIP rather than NSIP. So when you call somebody as NSIP, they will get worked up for antibodies against scleroderma and SLE and all that, whereas rheumatoid is more UIP tending. The NSIP pattern can be seen in all 4 of the, all 5 of these actually. But when they are seen in scleroderma, SLE, they're almost, you can't distinguish them apart. That's why the patients are worked up for all of them together. So all of the antibodies are done together, IgG and all that. And whatever lights up or whatever has positive results, they go down that route. And obviously then you have to examine the patient and look for the clinical symptoms. With scleroderma, you're going to look for the esophageal dilatation and the skin changes and all that. SLE is very heavily pleura-based. So SLE patients, when you think SLE, remember effusions, pericardial effusion, pleural effusions, pericardial thickening, pleural thickening. SLE is the one that goes towards the pleura. RA also gives pleural effusions, sometimes pericardial effusions. These are the ones that you need to think of, especially for exam point of view, the connective tissue diseases that like the membranes, so pericardial, pleural. They can be thickened, but very mildly, barely perceivable thickening on scan. They can be slightly enhancing, but fluid is what you're looking for. Scleroderma, Sjogren's, not so much. RA, I'll focus on more because RA is the one that is most confusing, because the RA patients can have not only ILD, but they can also have airways diseases. So RA is special in the sense that sometimes the ILD comes before joint manifestations of RA. So the patient may not know they have RA, or the joint comes first and the ILD comes later, or the ILD never comes. What can almost never happen is that they get the ILD but never the joint. And the ILD is almost never clean ILD. It's ILD as well as airways disease. So the airway disease they get is bronchiolitis. So the bronchi, the large airways, medium-sized airways have inflammation around them. So the airways can get thickened. So it looks like a bit like bronchiectasis with thick bronchi, inflamed bronchi. And when you have inflamed airways, you get infection. So superadded mild infection, atypical infection. The infection comes stream bud nodules. So fluffy looking nodules, dirty looking lungs, dilated bronchi, thickened bronchi is the airway problem of RA. So RA related airways disease. Airway disease is further divided into obstructive and non-obstructive. I'm not going to go into that today. The ILD can happen concurrently with the airways. Sometimes they can have only airways, but the ILD is usually never just ILD. It has ILD and airways. The ILD favors, and if you look at the pie chart, favors UIP more than other patterns. So it will start like probable UIP. By the end, it can be definite UIP pattern, and the patient has known RA, so they will label it, even if you report it as a definite pattern, a definite UIP pattern of lung fibrosis, and the history says RA patient, the diagnosis the patient will get out of the MDT is CTD-ILD. Very rarely they can present as diffuse alveolar damage. It's very rare, and the patients don't really tend to do very well when that happens. RA-ILD, like I said, when they are predominantly or only airway-related problems with RA or RA-related bronchiolitis. You have these strained blood nodules being the main problem, thickened airways being the main problem. And when you have ILD predominant problems, you have the probable or the definite UIP in this coronal case when you have the honeycombing, or you can have a mixture of both, a bit of ground glass, bronchiectasis, then you have ILD, so a bit of everything put in together. I know that's not really helpful in terms of you want a clear, I will look for this to call it RA-ILD. But the point to remember about RA-ILD is the patient will may present as joint problems. They may present with airway problems. The scan may be messy looking. There will be a bit of airway issues, a bit of ILD issues. So there's no easy answer, I'm afraid. I won't go into SLE and scleroderma because the thing to remember about them is they will present as an NSIP. And obviously, for exam purposes, you look for a dilated esophagus and all that. Moving on to drug-induced lung disease. Drug-induced includes pharmaceutical drugs and it includes recreational drugs. Different drugs favor different patterns. There is a lot of overlap. There are some exam favorites in terms of these drugs. Nobody expects anybody to remember all the drugs that cause different patterns. So nobody's going to ask you which drugs give you a fibrotic pattern of ILD, or which drug gives you isolated ground glass abnormality on drug-induced lung disease. So it's a bit unreasonable. And because there is so much overlap, what does happen is the exam history or the patient history in real life will say the patient is on this drug, and you will look at a scan that looks abnormal. And with abnormal, you will go through the different the pattern. Is there ILD? Is this an acute pattern? Is this, you will look for the pattern, is this UIP pattern? Is this OP pattern? Is this a fibrosis as an NSIP pattern? Is there just mosaic attenuation? There's a bit of ground glass, there's a bit of dark lung, I can't really tell what's going on. Any of those is worth describing, and any of those could represent a drug-induced lung disease. The only way of definitively diagnosing drug-induced lung disease is to stop the drug and follow up. Most of these recover with no sequelae. The lung heals very well when the insult is extrinsic. When you stop the drug, the lungs comes back within months to how it was, and the symptoms recover much quicker than that. Imaging recovery is delayed. Organizing pneumonia is the number one presentation you see of drug-induced lung disease. Is because it's so striking on a scan. It's easy to differentiate from other, for example, lobar consolidation or UIP, IPF. The OP pattern makes people think more down the drug-induced line than any other pattern. Nitrofurantoin, unfortunately, still very commonly oversubscribed by GPs for prophylactic of UTIs. It's seen and shouldn't be. It comes in the exam as well, and it gives an OP pattern. It can give a mosaic pattern. The very specific exam-related questions you will get is around certain drugs that are exam favorites. Chemotherapy drugs, there are so many of them, so don't bother learning around the names of the chemotherapy drugs or the immunotherapy drugs. Any of those you can Google when you have a patient presenting with a certain abnormality and see whether that drug is actually pneumotoxic. There's a directory, the national directory of drugs that are, because it is mandated by drug agencies to put your drug on that list if that drug is known to cause or has caused in significant patients pneumotoxicity. So that directory is free and accessible to everyone. So you can look up a drug that you've never heard of before and the patient happens to be on it. You can look it up whether that drug is actually pneumotoxic. The common ones you will hear are rituximab, nitrofurantoin, cyclophosphamide, methotrexate. Methotrexate is very commonly seen because methotrexate happens to be a treatment for RA. RA can give you ILD and methotrexate can give you ILD. So you can have an RA patient on methotrexate and the question is, does the patient have methotrexate-induced lung injury? And that's a really, really hard question. And the thing to look for then would be acute looking changes. And by acute looking changes, I mean diffuse ground glass, mode consolidation, dirty looking abnormality that has come on within weeks or months even. So the last scan was 3 months ago and the scan looked very different. Now they have new ground glass and the patient was put on methotrexate. So the acute looking changes should make you think of drug induced rather than purely fibrosis. Um, in terms of the pattern itself, unknown drug, that's your presentation. That's bilateral architectural distortion, ground glass tending towards consolidation. Can you think of any infection that would look like that? Can you think of ARDS that would look like that? Would pulmonary edema look like that? You can't really fit into anything else. And bizarre looking, interesting looking patterns that are bilateral, quite significant, involving all the lobes, should make you think of drug-induced lung disease. Methotrexate, like I said before, seen quite commonly, and it also recovers pretty well when you stop the drug. So that's the patient's recovery over weeks to months, and the patient improved with no sequelae. Cyclophosphamide, a chemotoxic chemotherapy drug, can give pneumonitis, can give you ILD, can give you drug-induced lung disease. All these terms you can use interchangeably because you're describing an acute or subacute abnormality. You can describe the scan as there are bilateral changes with architectural distortion, ground glass, areas tending towards consolidation in the right lower lobe. That should make you think of either atypical infection, so whether that patient has maybe COVID or any viral pneumonia that was really bad and the patient is immunocompromised, they look like that, or it should make you think of drug-induced pneumonitis. And over time, the lung, as it's getting put through that insult, will constantly be trying to heal itself. So it will start developing architectural distortion within days. So you can have acute inflammation and you can have distortion on the same scan. And over time, the acute inflammation, if the drug is stopped, will go away, and architectural distortion will take a bit longer to resolve and may never resolve completely. Imiodarone, exam favorite because they want you to look at the liver density and notice that it's a heart medication that can give you ILD. There's no specific pattern that you see of it for the lung. The feature that makes you clinch the diagnosis is the liver attenuation. And believe it or not, it's pretty fairly commonly seen in real life as well. Cocaine is also pneumotoxic. The abnormalities seen are seen in acutely unwell patients. Those patients have presented with a heart arrhythmia or cardiac arrest or ITU setting, and the lungs can look abnormal. The problem that happens with cocaine lung is because the patient lost consciousness and they had a cardiac arrest because they were on cocaine, and that's how they came to the hospital. If the question is, while that patient was collapsed, did he aspirate? Yeah, he might have. Or is that ground glass, pneumotoxic, pneumocyte inflammation because of cocaine? Either. So this patient happened to be well and conscious, no aspiration, and that was called as cocaine lung. But cocaine lung can look like aspiration pneumonia. It's predominantly ground glass, it's predominantly airway centered. It's usually bilateral. There is no clear zonal distribution, but it's an interesting scan to look at when you see it. Just at the end, I will talk about a couple of rare ILDs just out of interest and because they happen to be exam favorites, but I will pause here and see if you guys have any questions for me because we're ahead of schedule. We're going to finish in 10 minutes or so. If you have any questions, feel free to put them in the chat. The thing I would say to Shima is a lot of people find it confusing, and it's completely reasonable to find it confusing. The one thing you can look at for organized pneumonia, like I said before, a lot of organized pneumonia patients do get diagnosed incorrectly as bronchopneumonia. They get, if they're unwell to be enough to be admitted in the hospital, they inevitably get put on antibiotics, and then the patient doesn't improve, and then somebody thinks of giving them a shot of steroids or a course of steroids, and they do really well. And that's how the timeline happens fairly commonly. The organizing pneumonia, if you see the distinct pattern of bronchocentric and clear subpleural patches of consolidation, bronchopneumonia shouldn't really give you that. Bronchopneumonia can have patches that are more central and the patches that are more peripheral. There can be a bit of ground glass around it, whereas organizing pneumonia is more artistic looking, is one way of explaining it. Is hypersensitivity pneumonitis the same as external allergic alveolitis? Yes, it's the same disease, two different names. Is there any time gap to diagnose OP rather than infective pneumonia? No, you don't need. You can have organizing pneumonia today and be diagnosed with it. There is no time frame you need to wait. What is that entity with central dot sign with thick wall? Central dot sign, central dot of air with thick wall? Don't really understand the question. What is the entity with central dot of air with thick wall? Don't understand the question. Sorry. If you can explain it a bit better, I may be able to answer that question. From a complete new starter, how do you tell the difference between atelectasis and reticulation? Reticulation are smaller lines, multiple lines sitting around the pleural space. Atelectasis is a band, a thin band, a long line that will cross multiple pulmonary lobules, whereas reticulation is a small, very small line. Different, and they should be multiple. You can't have one little strand of reticulation. It'll be a diffuse abnormality, multiple lines, subpleural, thin, straight. Can ground glass haze be superimposed on honeycombing? No. And I would like you to be able to tell me why that is. Because honeycombing is dead lung. It is non-existent lung. So if there is nothing there, there is nothing to get infused with ground glass abnormality. There's nothing to fill. If there is a cyst that is filled with anything, it will be an emphysematous cyst, or it will be a cavity in the lung that has got an infective and an air fluid level. Maybe that's what you mean, but honeycombing shouldn't have anything imposed on it. If mosaic perfusion, where expiratory scans shows air trapping, can we give differential of pulmonary versus small airways disease? If you have expiratory scan that shows you air trapping, that gave you a definitive diagnosis of air trapping and airways disease, you can then kick pulmonary vascular abnormalities out of the window and give only airways disease. Because vascular abnormality will not give you air trapping, whereas airway abnormality will. Okay. Moving on, last bit is the unusual ILDs. These are the ILDs you will see more commonly in larger tertiary care centers, and you will see them in transplant centers. You will see them in exam setting very commonly. LAM, LCH, and there's a new kid in the block called GL-ILD. LAM is lymphangioliomyomatosis. It is actually a tumor that is a proliferation of the LAM cells in the lung, kidney, and the lymphatics. People think it is only genetic, but it is actually more sporadic than it is inherited. There are guidelines to diagnose somebody with lymphangioliomyomatosis. There are guidelines called from the Japanese Society and the American Society from 2017. Because if you see features of LAM on CT, you ideally want two other features from the ones listed below. So you want to see the tuberous sclerosis complex, or you want to see renal angiomyolipoma, chylothorax, before you can label somebody with LAM. LAM is a progressive disease. It is a disease with no cure, the only cure being transplant. It is not an indolent disease. So when these patients you can't really call somebody LAM and then expect them to do okay. They will inevitably progress if they were actually LAM, and they will end up with end-stage disease when all of the lung parenchyma will get replaced with cysts. and there will be nothing to irrigate the lung, and the transplant will be the only thing left. Patients, usually young females and non-smokers. The abnormality is diffuse, as in there is no zonal predominance in terms of next to pleura, away from pleura, which lobe, which position. It can be anywhere in the lung. They are cysts. So as an entity of a cyst, they require to have a wall. These walls can be thin enough that you can't see them. For example, if this was the scan you had, and you were doing busy on call with 80 scans during the night, and this was a scan, you would dismiss it in less than 5 seconds and call it emphysema and not look back. And that is how these patients do get go undiagnosed, only when it is so advanced and prominent and bilateral, and the underlying lungs happen to be very healthy that you can see the cyst wall. Do they get picked up? When they have cysts, the cysts are the only abnormality in the lung. So LAM patients don't have anything else. It's a normal lung with cysts, no reticulation, no ILD, nothing. In otherwise a young, healthy adult. When it's pretty advanced, they can present with complications. So the complication they will have is one of those cysts will pop. They will have a pneumothorax, or they can present with the chylothorax, because those LAM cells can also proliferate in the lymphatic channels in the chest. So they can present with recurrent chylothoraces. The other disease to think of is LCH, Langerhans cell histiocytosis. The understanding now, and this has evolved over the last few years, is that LCH is just within the spectrum of smoking-related lung disease. So smoking-related lung disease can have anything from just emphysema to just a bit of central lobular upper zone nodules, to both, to diffuse bilateral ground glass, so a DIP sort of pattern. And over time, they can have cysts. So these cysts that these smokers develop are inflammatory cysts. So because of that, they are ill-defined, like almost starry, spiculate-looking small cysts bilaterally. And over time, these cysts cavitate and turn into, these nodules cavitate and turn into cysts. To clinch the diagnosis of LCH, you want follow-up scans, and you want to be able to find the cyst that on the previous scan was a nodule. So you can be sure that this is the nodule that cavitated and became a cyst. And if you see multiple nodules turning into cyst, you are very confident in labeling it LCH. For exam point of view, they will be in a smoker. The extreme lung bases will be preserved. They have thin wall cysts. They can be slightly thickened, but they can be, because they're in a smoker's lung, it's a messy looking lung. They can look thickened. They can have a confluence of cysts, or they can be bizarre shapes, but rarely do they exceed more than 5 to 10 millimeter. So this is what I mean by the ill-defined nodules. The nodules can look almost spiculated, but because this spiculation is fluffy looking, it doesn't really make you think of metastatic deposits, as a first instinct, because some of them are more dense, some of them are more fluffy, and none of them are more than a centimeter. They're irregular looking, speculate looking, but not like the nodules you see in metastatic disease. And over time, these nodules cavitate and turn into cysts. And that's your LCH. That's, I think, my last slide. I will pause here and ask you guys if you have any questions before we finish. Pulmonary nodules coalescing to form a patchy area of consolidation. It indicates benign etiology. It indicates granulomatous inflammation. So sarcoidosis can look like that. TB can look like that. Rarely, even unfortunately, metastatic disease can look like that. But the word coalescing nodules is used for TB and sarcoidosis. Is reticulation same as interlobular lobular septal thickening? The process is the same. Reticulation just means lines perpendicular along the pleural surface, but it's the same pathology that looks like that. GL-ILD is a new group of ILD that's seen in patients who have combined immunodeficiency syndrome. So patients, I don't know if you guys There was a very famous movie, I've forgotten the name, kids who have very SCID, so severe immunocompromised immunodeficiency that almost they call bubble babies. So they have to stay inside and always be protected, and they have all sorts of immunodeficiencies, G cells and all that, lymphocytic, neutropenic, all that. So this is ILD that is associated with those patients. It is very, very rare. It looks like a bronchocentric, nodular looking, basal predominant. It looks like atypical infection. So these patients keep getting worked up for mycobacterium infection. So the airway is inflamed, and that is actually an ILD, and that is GL-ILD. There's no history of smoking exclude LCH. No history of smoking excludes LCH in male or female. Okay, feedback link, please. There you go. Primary ILD. In case of, no, I think I've moved up by mistake. What is the difference between DIP and LCH? They are both different ends of the spectrum of smoking-related ILD. So smoking-related ILD can have RB ILD, which is nodules, central lobular nodules. They can have emphysema. They can have both. Emphysema is usually trickling along every single alveoli. DIP is discriminative interstitial pneumonia. It is diffuse ground glass. It looks like there is something on the lung and you want to clean it. It's a diffuse, like almost like a veil coming over the lung on both sides. And that is the extreme last presentation of smoking. The very heavy smokers, chronic smokers will have lungs like that. And the only treatment is stopping smoking cessation, basically.